Hello, my name is Roland Veltkamp. I am the head of Department of Neurology at the Alfried-Krupp Krankenhaus in Essen, Germany, and I'm also a professor of neurology at Imperial College London. Let me start by saying that brain hemorrhages in young patients below age 50 are more frequent than we have previously thought. Between age 18 and 44, the annual incidence of brain hemorrhages is about 1.9 per 100,000 persons, and it increases about tenfold between age 45 and 54. There are well-known risk factors of brain hemorrhage in the young. Most importantly, hypertension, which can also be a direct cause. It's heavy drinking of alcohol, defined as more than 2 drinks per day. It is smoking, but there are also defined structural causes. The causes of brain hemorrhage can be classified according to the SMASH-U acronym classification. S stands for structural, meaning vascular malformations, but can also mean tumors. M for medication and drugs. A for amyloid angiopathy, which is a relatively rare cause in the young. S for systemic diseases. H for hypertension. And the U is for undetermined causes, which are more frequent in the young than in the elderly. Young patients with intracerebral hemorrhage have to undergo a wide variety of imaging tests. First of all, brain imaging using MRI usually. Secondly, vascular, non-invasive vascular imaging using MR angiography or CT angiography can provide information on vascular malformations, sometimes also cerebral sinus vein thrombosis. In some cases, digital subtraction catheter angiography is needed to diagnose conditions such as reversible cerebral vasoconstriction syndrome. The management of acute brain hemorrhage in the young does not differ very much from management in the elderly. First of all, patients should be treated on a stroke unit or on a neurocritical intensive care unit. Blood pressure should be rapidly controlled with a lowering of the systolic blood pressure between 140 millimeters per mercury. Some patients may require hemostatic measures, especially patients on anticoagulants such as vitamin K antagonists. On top of conservative measures, recent data suggest that neurosurgical procedures are an option, especially for patients with large, deep intracerebral hematomas. A recently published trial called SWITCH has shown that hemicraniectomy increases the surviving of patients without causing an increase of the number of patients with very severe disability. Another scenario is patients with lobar hematomas, superficially located hematomas. A trial called ENRICH recently showed that a minimally invasive procedure can effectively reduce hematoma size and that it can also reduce the disability of intracerebral hemorrhage patients. And our expectation is that these findings are most relevant in young patients with intracerebral hemorrhage.